So I'm gonna discuss about the loop combinations, which is the loop agents and thiazides. So first is, what is diuretic? Diuretic is a medicine which increases the amount of urine that pass out from your kidneys, sometimes called water tablets. So I'm gonna differentiate the loop agents from the thiazides. So first is loop agents. It is the most powerful class of diuretics. Its MOA is inhibiting sodium, potassium, and chloride co-transporter in the thick ascending limb of Henle. While thiazides are less potent than loop agents. That is why it's more preferable ang thiazides rather than loop agents. It's because thiazides are less potent. So its MOA is inhibition of sodium chloride co-transporter in the distal convoluted tubule. So these are the some reasons. Some patients are refractory to usual dose of loop diuretics or become refractory after initial response. These agents have a short half-life of 2 to 6 hours. So refractory is kanang unmanageable. It means that kanang naiuban nga patients nga dili nila makaya ang kaisog sa tambal, mao nang i-combine siya another diuretic para dili ka siya isog. So renal sodium retention may be greatly increased during time period when the drug is no longer active, because ang primary target of our diuretics is to reduce the renal sodium. Yeah. It was hoped that continuous loop diuretic infusions would be useful in treating patients with a heart failure resistance. But one high-quality study did not show benefit for continuous loop diuretic infusion as opposed to bolus doses. After the dosing interval for loop agents is minimized, the dose is maximized. The use of two drugs acting at the different nephron sites may exhibit dramatic synergy. So dramatic synergy is the total effect is greater than the sum of the individual effects. So loop agents and thiazides in combination often produce diuresis, which is increased urine output by the kidney, when neither agent acting alone is even minimally effective. So these are several reasons for this phenomenon. First, salt reabsorption in the thick ascending limb, which is located here, or the distal convoluted tubule. When the other it can increase when the other is black. So inhibition of both produce more than an additive diuretic response. So mas daghan siya ma-absorb mo nang murag mas increase iyahang pagawas og sodium. And second is thiazide diuretics often produce a mild natriuresis, which is the increased renal sodium excretion in the proximal tubule, which is located here. Kay in this part nag-absorb siya daan og sodium chloride. Muna inigabot niya sa thick ascending limb, which is the main site of the loop agents. Mas increase iyahang absorption of sodium chloride, ATP-base. So combination of loop diuretics and thiazides can therefore reduce the sodium reabsorption. It can also mobilize large amounts of fluid even in patients who have not responded to single agents. So it is essential that close hemodynamic monitoring. So what is close hemodynamic monitoring? Close hemodynamic is a measure the blood pressure inside the veins heart, and arteries. It also measures blood flow and how much oxygen is in the blood. It is a way to see how well is the heart is working. So next is the potassium-sparing diuretics and the proximal tubule diuretics, loop agents, or thiazides. So potassium-sparing diuretics are medicines that increases diuresis or urination without the loss of potassium. They are generally weak diuretics and work by interfering with the sodium-potassium exchange in the distal convoluted tubule of the kidneys, or as an antagonist at the aldosterone receptor. So, why are there potassium-sparing diuretics? So, sometimes when you take diuretic, you lose too much potassium from your body along with the extra water you pass. This can make your potassium levels low, which is very dangerous. The potassium-sparing diuretics help to stop this happening. They can be used on their own but are commonly used in combination with another type of diuretic. It's because weak diuretic lagi siya. So, these have two groups of potassium-sparing diuretics, which is the aldosterone antagonist and the sodium channel blockers. Aldosterone antagonists has the spironolactone and the eplerenone. So, ang ihang MOA is to antagonizing the aldosterone. What is aldosterone? A hormone which gets into the cell, binds to the intracellular receptor, and stimulates transcriptional genes including the sodium channels, sodium-potassium ATPase excretion. So, as a result, reduces the synthesis of proteins that activate the sodium channels, decrease the number of sodium-potassium ATPase, which is automatically leads to potassium retention. And while the sodium channel blockers are, its MOA is blocking the sodium channels only. So, ang possible side effects of the aldosterone antagonist is tummy ache, dry mouth, feeling sleepy, headache, feeling dizzy, due to low blood sugar, weakness, and hyperkalemia, which is the excessive potassium intake. So, ang sodium channel blockers have its side effects also, which is tummy upsets, excessive hair growth, sexual problems, dizziness, and hyperkalemia. So, what are the main uses of potassium-sparing diuretics? First is to prevent low levels of potassium or hypokalemia occurring when the diuretics are used. Like, katong loop diuretics and thiazides can cause hypokalemia. Mao ni siyang i-combine siya og potassium-sparing diuretics in order to not dili kay siya maubos iyang potassium. In the treatment of heart failure, in this condition, fluid accumulates in your body due to the heart not pumping blood around the body as well as it normally would. So, you may become breathless. Your ankles and legs may swell with extra fluid in the tissues, which is edema. Other causes edema can also be helped by diuretics. Muna siyang potassium-sparing diuretics. So, in helping to reduce the condition called ascites, where fluids build up inside the tummy, this can happen due to various conditions such as cirrhosis of the liver and certain kinds of cancer. Lastly, in treating high blood pressure, hypertension, usually in a combination with other medications.
So we're here to report about the hematostates and non-hematostates. So, edema or hematostates means there's a watery fluids in cells, tissues, and other body cavities. A common reason for diuretic use for reduction of peripheral or pulmonary edema that has accumulated as a result of cardiac, renal, or vascular disease that reduce blood flow to the kidney. So, in heart failure, it's the decrease of the ability of the failing heart to sustain adequate cardiac output cause the kidney to respond as if there is a decrease in blood volume, increasing sodium and water retention. In treating heart failure patients with diuretics, cardiac output in this patient is being maintained in part by feeling pressure. Excessive use of diuretic may diminish venous return and further impair cardiac output. Systemic congestion is the hallmark of this disorder, and loop diuretics are common for treatments of heart failure. Kidney disease and renal failure. When renal failure is severe, diuretic agents are of little benefit because glomerular filtration is insufficient to generate and sustain an diuretic response. However, there is still interest in the question as to whether diuretic therapy can alter the severity or outcome of renal failure. This is because the non-oliguric forms of acute renal failure have better outcomes than oliguric acute renal failure. For patients with kidney disease, acetazolamide must usually be avoided because it causes sodium bicarbonate excretion and can exacerbate acidosis. And potassium-sparing diuretics may cause hyperkalemia. Hepatic cirrhosis. Liver disease is often associated with edema and ascites, and in conjunction with elevated portal hydrostatic pressure and reduced plasma oncotic pressure. For severe ascites and edema, diuretic therapy are very useful, but in cirrhotic patients are often resistant to loop diuretics because of decreased secretion of the drug into the tubular fluid and because of high aldosterone levels. Combination of loop diuretics and an aldosterone receptor antagonist may be useful in some patients, but should be cautious when using aldosterone antagonist to cirrhotic patients, for it can cause severe hyperkalemia. Vigorous diuretic therapy can cause mild depletion in intravenous volume, hypokalemia, and metabolic acidosis. Hepatorenal syndrome and hepatic encephalopathy are the unfortunate consequences of excessive diuretic for cirrhotic patients. Idiopathic edema or fluctuating salt retention and edema. Pathophysiology is still obscure, though some studies suggest that surreptitious intermittent diuretic use may actually contribute to the syndrome. Spironolactone is used for idiopathic edema and should be managed with moderate salt restriction.
The next topic is about the edematous states. Non-edematous states are hypertension, nephrolithiasis, hypercalcemia, and diabetes insipidus. Hypertension, thiazide diuretics are widely used for treatment of hypertension. The diuretic and all vasodilator actions of thiazides are useful in treating virtually all patients with essential hypertension and may be sufficient in many. Diuretic enhance the efficacy of many agents, particularly ACE inhibitors. The next is nephrolithiasis. This can be treated with thiazides diuretics, which enhance calcium concentration. Fluid intake should be increased, but salt intake must be reduced, since excess atory sodium will overwhelm the effect of thiazides. Hypercalcemia can be a medical emergency because the diuretics reduce calcium reabsorption significantly. They can be quite effective in promoting calcium diuresis. Once the diuresis begins, the rate of saline infusion can be matched with the urine flow rate to avoid volume depletion. Diabetes insipidus is due to either deficient of NDI and thiazide diuretics have been found to be very helpful in treating